Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome to our Health Literacy webinar. My name is Noor al-Huda al-Hashim, the head of the NICC Health Literacy Program, and I am thrilled to moderate our webinar today. We're excited to once again welcome Dr. Sabbagh to our virtual platform. She has been sharing her expertise with us since the start of the pandemic, and we are thankful to have her with us today. If you have any questions for Dr. Sabbagh throughout the webinar, please share them in the Q&A box, and we will address them at the end of our webinar. You will also find a recorded version of this webinar on Noor Ohio's YouTube page, inshallah. While COVID case numbers are increasing and the end of the pandemic remains unpredictable, schools are reopening and employees are returning to their normal schedules. While our society has also arrived at vastly different conclusions on how to live with this pandemic. Today, Dr. Sabbagh will share with us what we need to know at this unexpected stage of the pandemic, including current statistics, testing, vaccines, and more. Dr. Wissam Sabbagh currently works as an infectious disease consultant at Ohio Health Riverside Methodist Hospital. She is a graduate of Damascus University School of Medicine and completed her internal medicine residency and infectious disease fellowship at Wright State University in Dayton, Ohio. Dr. Sabbagh worked there for 11 years before moving to Columbus last year with her husband and 3 kids. Dr. Sabbagh, thank you so much for joining us, and I will hand over the virtual mic to you, inshallah.
Thank you so much. Thank you for the nice introduction, and Jazakumullah khair. Good afternoon, everyone, and thank you for joining us on this Sunday afternoon. Hopefully we'll give some useful information. We know there is a lot to talk about, but I'm gonna try to be really talking about what's new since we talked a few months ago. And at the end, if you have any questions, I'll be happy to answer. So with that, I will go ahead and get started. And again, as Sister Noor mentioned, I was asked to talk about really the newest as far as things we know now that we did not know before, as well as testing and treatment and vaccine. So we'll talk about these 3 major things. Just to start with the current numbers of COVID-19 in the United States since the beginning of the pandemic, and that's, I mean, you can see the numbers are fluctuating. Actually, as of today, we have over 5 million total cases in the United States, and we have 168,069 deaths in the United States. So it's, again, the numbers are still growing. Like since yesterday, we had 1,100 deaths and 54,000 new cases in there. So with that, I'll go ahead and get started with what's new. First of all, terminology, it's always important. The virus, actually, the virus itself, it's called SARS-CoV-2. That's the newest name. The disease itself that the virus causes is called COVID-19. So when I talk, you know, I mean, it's the disease is COVID-19. The transmission, what's new about the transmission? We always know that droplet, respiratory droplet, is the main transmission when it's person to person. We knew before that if the, contact of contaminated surfaces if you touch some area with the virus and then touch your mucous membrane, eyes, nose, mouth, that can cause the disease. What's new is airborne transmission. Actually, still it's not confirmed in the community, but if you read about it, you're gonna read, like in some research lab, they found that there is airborne transmission. And just to make it clear, airborne actually is the smaller particle that carry the virus. Droplets are larger ones. Usually when we talk or sneeze or cough, these little droplets doesn't travel more than like maybe 2-3 feet. And that's where the social distance guidelines came from. The airborne are smaller particle and travel further and it can stay in the room. So again, as of yet, there is no confirmed transmission in the community by airborne. The other thing, the newest recommendation from the CDC when it comes to protection and face masking and everything, the face covering. So now if you work in an area with high transmission rate or in public places, you are required to wear a face cover. And that actually is gonna be effective for school teachers, healthcare workers. Actually now in the hospital, we wear a mask and we wear a face shield. So that's the newest thing. One more thing as far as incidence, actually at the beginning we thought children are spared and not affected by COVID-19. In fact, actually they can get the COVID-19. And in the past 4 to 6 weeks, actually we have 90% more children affected by the disease. Usually they get a milder case and their symptoms are really a little bit different, but still, I mean, they can have actually, we've seen some children with severe cases requiring hospital admission and unfortunately ICU care and even death. But again, it's a smaller number of, it's a smaller number. Risk factors of COVID-19 did not change much. We know that advanced age is a risk factor. Other medical conditions can actually, can predict bad outcome. If you have diabetes, especially uncontrolled, high blood pressure, heart disease, kidney disease, liver disease, and actually obesity, I highlighted that because now there are more and more studies associating obesity with the body mass index more than 30 with high mortality rate, meaning they're more likely, patients who are obese are more likely to have bad outcome and maybe die from the disease. The new thing, HIV actually now is a risk factor, and we know immunocompromised conditions are all in general risk factor for bad outcome. The symptoms, again, we're seeing more and more symptoms, and it's difficult to understand how different areas of the world are having different symptoms. It's really a unique virus. We all know that with fever, chills, cough, problem breathing, difficulty breathing, muscle ache, headache. These are all the symptoms like we've seen before. Loss of taste and smell, sore throat. Now we're seeing more and more GI symptoms. So the CDC added nausea, vomiting, and diarrhea. As like it's also one of the questions when we screen for symptoms, we ask about nausea, vomiting, and diarrhea. And the newest thing, I'm sure you've heard about this. I mean, now we have a population called the long haulers. These are like some people who had COVID-19 recently, and they still have symptoms few weeks or even few months after. And these are, again, we are seeing them in the primary care offices. There are support group online. You're gonna hear more and more about it. I mean, we know about like post-Lyme syndrome and certain diseases, you can have syndrome after that. This is a similar thing. It's gonna be, I mean, maybe 30% of people can have more prolonged symptoms. This is a study conducted by the CDC recently, and they asked people who were positive for COVID-19, and among the responders who were like 292, 35%, they were still having some symptoms within like 2 to 3 weeks after testing. And the most common ones were fatigue, cough, and headache. And again, I've seen some people who had joint pain, low-grade fever, difficulty breathing. So you can see a variety of symptoms. And that's actually, this is again, just to give you an idea. So in blue here on the left, you can see the symptoms of acute COVID-19. And we talked about most of these. And in red on the right here, you can see the post-COVID-19 follow-up. And you can see those symptoms again, most commonly fatigue, shortness of breath, joint pain, chest pain. You can see that up to weeks or months after that. Just I want to mention something. I mean, when we talk about testing, these people might have positive test maybe weeks later, but doesn't mean that they're still infective or infectious and they can spread the virus. We'll talk more about it when we talk about testing. I wanted also to put this slide because now we're approaching fall and winter, and we're going to see all kinds of viruses, including the flu and the cold viruses. And the symptoms are really, especially the flu and the COVID-19, they're going to overlap. There is a lot of overlap. I mean, again, fever, chills, body ache, sore throat, dry cough. These are all you can see both in flu and in COVID-19. With the cold, it's going to be a little bit different. Usually it's more milder disease. You don't see this high fever. You don't see this extreme fatigue. And you don't see like the significant shortness of breath. The flu and the COVID, again, are very similar. The incubation period is different. But again, now, I mean, they're working on some testing in the emergency room and in the hospital. So when somebody goes, like starting September, when somebody goes to the emergency room with flu-like symptoms, they can test for both and decide which one they have. This is again another diagram just to see some differences between COVID-19 and the flu, because this is going to be a major problems when the flu season starts, and it's starting actually very soon. And you can see like few major differences, like the incubation period. So the time between acquiring the virus and having symptoms for COVID-19 is 2 to up to 14 days. For the flu, usually it's shorter, it's 1 to 4 days. Treatment, we know the flu, there are some antiviral medication for treatment. Vaccine, there is a vaccine for the flu each year. But the most important thing in the slide here on the bottom, the mortality rate with the COVID-19 is 3.2% versus with the flu, it's 0.1%. So that's a huge difference in death rate comparing the two diseases. So these are like really the main differences since we talked a few months ago. So now testing, what are the available tests and when do we order each test? And just hopefully that will help you get an idea about testing. First of all, there is no perfect test and there is no really ideal test for COVID. We have a few tests, but none of them are perfect. And the most important thing to interpret the result based on the clinical scenario. So first of all, if anybody has symptoms, they should, the first reaction should be quarantine them. I mean, for somebody to quarantine themselves immediately and call their physician. If they don't have a primary care physician, they can call the emergency room, the health department, get some information, and just follow the directions. They don't always have to go to the hospital, or staying at home is really the main thing if they have mild symptoms, or if they have, to start with a phone call, I think it's a good idea. If they don't have any access to those, they can always call the Ohio Department of Health and get some guidance. And because actually, if you check the website, they have some, what it's called like pop-up testing centers, and it changes every week. So that's gonna help you see where you can get tested. The other circumstances where you can get tested, actually, if you have any upcoming procedure or hospitalization, usually, you're required to have testing a few days before, or for any travel requirement. So if you have no symptoms, you can go to your retail pharmacy or call your, again, local health department and get some help as far as where can you get the test done. Testing, we have a few ways of testing. The first one, and it's the most advanced one, and it's the most sensitive one, is the molecular testing. And by this, it's called PCR, if you hear that. It's, there are so many companies with different PCR. And this actually will test for the RNA of the virus, or the genome of the virus in the throat. And that's actually, it's the most sensitive test if you have symptoms. So if you if you suspect COVID-19 and if you have no symptoms, the sensitivity is a little bit lower, but it's still best than any other test. Again, this is very expensive, and this is usually, it's done in hospital setting. The other one, there is like the antigen test, which is usually test like the virus molecule, like the protein in the virus. Still a very good screening test, and actually it's used for screening purposes. The sensitivity of this test is about like 81 to 90%. So again, it's not perfect, and it should be interpreted based on the clinical scenario. One thing I want to mention here, and I'm sure you've all heard about the incidents where our governor, DeWine, actually tested positive, but it was a false positive result. And then 2 other tests came back negative. So the initial one was antigen testing. So this one, there is actually a possibility of false positive result. So the first one was positive, and then they did 2 PCR after that, and they were both negative. So these 2 tests, actually the molecular test and the antigen test, are usually, detect like particles of the virus in the nasopharynx. The antibody test is different. Usually, actually, it tests the response of the body to the virus itself. It's a serologic testing. It's a blood test, and usually, if we acquire any infection, our body form antibodies, and that's what they check for. There are actually more than 30 antibodies that we know of for COVID-19 so far. There are so many tests. So again, that's one of the tests that when it's interpreted, it should be interpreted by a physician with the patient, and we should know why it was done. So usually we don't do this test. We don't do it just to diagnose the disease, again, unless, it's more for statistical purposes. And actually, or if we have somebody with positive PCR for a long time, and again, we'll talk more about that, or like positive test, but they have no symptoms for a few weeks, this will help actually figure out if they had, that's where this test can be helpful. And again, when you get the result, there is no positive or negative. You can, you see detected or undetected. So again, it should be interpreted with the physician and the patient. Speaking of that, I just wanted to mention that with the antibody in the serum, that's where the convalescent plasma actually was recommended as a treatment, because they take the antibodies from the healthy person who had the disease, and now they form antibody and they transfuse it to the people who has the disease, and theoretically that might help. So now this is a very helpful slide. If you I'm going to take some time going over that. This blue curve is the viral replication in our body, and actually it starts in the nose and pharynx and then spread down to the lungs, and then almost all your body actually can have RNA of the virus. So you see, actually it starts here. This is like where when you acquire the virus, and you see the viral replication goes up very high within a few days and then start going down slowly. So I want you to pay attention to this area where actually 8 weeks later, and you can still have little blips of the virus replication. And that's important because sometimes, the patient might have any symptoms and they're feeling great, but if you do the test, the PCR test specifically, because it's very sensitive and it tests very small particles of the virus, it can be still positive. This is actually the dotted line is the antibody response. So you can see that within 5 days after the infection, you start forming antibody. And actually the sensitivity of this test initially is 25%. And the more you go further into the disease, within 4 weeks or more, actually the sensitivity of the test is over 90%, approaching 98%. This is the transmission potential. And again, you can have some transmission when you are carrying the virus, even before having symptoms, but the peak of transmission is really when you have symptoms. And that's where the recommendation is, when you have any symptoms, to stay at home and wear your mask and all that. And this can, last longer. And the inflammation, that's where, again, when you always hear about COVID-19, where actually it starts as a respiratory disease, and then you have inflammation in your body, and that peaks within a week or two. That's where, when we treat, that's one of the options, is just to use medication that suppress this inflammation response in the body to decrease the activity of the severity of the illness. So I hope that will help. Testing, we can take the sample. With the first two, like I mentioned, the antigen test and the PCR test, we can do nasopharyngeal swab, and that's actually, they go through the nose, back to the throat, and that's actually, it's a very uncomfortable test, and it should be done by an expert hand, otherwise you can have some problems. Actually, the sensitivity is higher. Actually, it's the best specimens through this. If for some reason the patient cannot tolerate it, or the person who's doing the test cannot do it, they can do the oropharyngeal swab, which is like a mouth swab. Similar to like a strep throat swab. There is also some newer tests. Actually, we talked about them before, but finally, actually, as of yesterday, it was the FDA approved the first saliva test, and that's actually, it's kind of like a point of care test. It's going to be hopefully it's going to be very easy to use. It's going to be very cheap. They're expecting about maybe $10 a kit. And basically what they do, you spit on a piece of paper or like a little device, and it tells you positive or negative. Again, we are hoping that it's going to be used widely when schools open and we start doing more testing to the community. That's actually will allow for what's called pooled sample testing. And by that, they collect samples from different people, 10 or 5, or depends on what the test allow, and they can do pool testing. And if it's positive, and then they can take those people and do individual testing. it's gonna save money. It's gonna do like more information. It's gonna help with the epidemiologic studies. The blood test, I talked about it, and that's the antibody test. Again, it should not be ordered to make a diagnosis of a disease. Again, sometimes we order it for different reasons. If we have like somebody who has symptoms, we are not sure, and the PCR was negative, and we don't know if they had COVID or not, we can order that. And again, even with that, again, it should be interpreted really carefully. So treatment and vaccine, what's new about treatment and vaccine? Treatment, when we talked about this a few months ago, we said there was no really FDA approved treatment for COVID-19, and that's actually still the case. There is no confirmed treatment. Few things we're trying and few studies came up with different medication, but there is really nothing approved as of yet. The new one that really now we're using in the hospital, and actually it came, actually the study came a few weeks ago. It's a dexamethasone, which is a prednisone, similar to like any prednisone we use, all shape or form. It's a cheap medication, it's widely available. And actually this study from England, it's called the Recovery Trial. It's a very famous one because it's a game changer when it comes to COVID-19. They studied 6,000 patients, and they found that using dexamethasone 6 milligram every day for 10 days reduced the death rate by 1/3. That's very promising. That's very good. Now, it should be used. The one thing I want to emphasize, it should be used in hospitalized patients with hypoxia, meaning low oxygen level. So they should be requiring, if they are requiring oxygen or they are on the ventilator, that's when dexamethasone should be used. I know in some areas, are ordering prednisone for outpatient, and that's actually not recommended. The benefit of dexamethasone is for people with low oxygen level. So again, that's a game changer. And actually it's funny because when I did this talk a few months ago, we said dexamethasone or prednisone in general was not recommended for COVID-19. And actually we said avoid it. And actually we know that prednisone can actually harm people, with the viral pneumonia. But again, this study changed everything. And now it's actually recommended by CDC. And in the hospital we're using, that's actually the most commonly one we're using is dexamethasone for people who are hypoxic with COVID-19. The other one that's used in the hospital, remdesivir, again, a few months ago was new, now it's more available. Actually, we're using it in the hospital through compassionate use. Soon, the hospitals are going to be purchasing the medication. It's so far the only antiviral medication in the United States that showed some, I would say, effectiveness in vitro. And we're still doing studies and trying to evaluate if it's really helping or not. It's very expensive. Actually, it's a few $1,000s per dose. It's actually the most benefit for the patients who are on oxygen and did not require ventilation. So there is actually certain criteria we follow when we're going to use it so far. And initially it was anybody with high, it's a complicated process, but just to let you know, same thing, people should be on oxygen to qualify, and preferably not on the ventilator. That's the newest thing, because now they said, if they are not on the vent, they are more likely to benefit from remdesivir. The few other things like interleukin 6 pathway inhibitors, that's one example, tocilizumab. These are the medications that we usually use for multiple sclerosis, for rheumatoid arthritis. Usually it's suppressed like the immune response, suppress the inflammation in the system. And that's where, that's the idea of using these medication again, when we see lots of inflammation and inflammatory markers are elevated. Again, I wouldn't say, I cannot comment on the effectiveness on this medication, but I would say that's, we're using everything and trying all what we can. But again, the results are still, nothing really is like very promising so far. The monoclonal antibodies, again, it's multiple ongoing studies going on for this class of medication. Convalescent plasma, that's actually, we're transfusing lots of plasma. And if the patient has life-threatening COVID-19, usually most likely they would qualify for that. And that's why, the Red Cross, actually, they have like, you can contact them and enroll the patient, and they can provide match the blood type and provide the plasma. Again, we've been using this for a while, and we have a lot of information again, but nothing again. When we discuss the results, it's like 50-50. Hydroxychloroquine is very interesting because, again, it was recommended and it was one of the first recommendation. Now, later on after March, April, we had some studies that showed some no effectiveness, and then a newest study that showed that it might do more harm than good. There are some studies actually, this is the most recent one from Detroit. Actually, they studied hydroxychloroquine, which is Plaquenil with azithromycin, and it showed some benefit. But again, the American Heart Association said, this combination could be really dangerous for the heart. So at this point, we have very little evidence to support the use of chloroquine or like Plaquenil to treat COVID-19. Azithromycin is an antibiotic. It's used usually for for bacterial pneumonia. It has some anti-inflammatory properties. That's where the idea came from. So I would, again, it's not recommended to be used widely, but if we have like the perfect clinical scenario, it could be helpful. Other things that, we have some studies here and there: nitric oxide, colchicine, the one used for gout, vitamins, vitamin C, zinc. But again, none of those are really, there is no strong recommendation to use any of those. Anticoagulation, I want to mention that because I know for example, in Syria, they called me and they're giving anticoagulation for anybody with COVID-19, and that's very wrong. Actually, it's going to cause more harm than benefit. We know that with COVID-19, you have more tendency to form blood clots. That's, because of the inflammation in the blood vessel, that's true. But anticoagulation is not recommended for everybody. Usually we do certain blood tests, and if they qualify and then we use anticoagulation. Actually, I've seen really bad outcome from Lovenox or some other agent used for anticoagulation, and the patient end up dying from like intracranial bleed, like brain bleed, if you want to call it that. So I would be really careful, using anticoagulation. So now the last thing I'm going to talk about, and again, I know most people are really eager to know what do we know about the vaccine? When is the vaccine coming? That's, we're waiting for the vaccine, but unfortunately, the short answer is we don't know if the vaccine, even if the vaccine is available, there's no way to know if it's really effective or not. We don't know who's going to benefit from the vaccine. We don't know the side effects. We don't know the immunity, if it's going to last for long or if it's just like it's going to last for a few months, similar to what we have with the influenza, and we need to revaccinate again. That's, again, so many things we don't know. But just in general, just to give you some like update, the Dr. Fauci from the CDC said that, they're expecting tens of millions of vaccine to be available in early 2021. So most companies are, working now on manufacturing, increasing their manufacturing capacity. So when the vaccine is available, they can hopefully produce millions of doses and make it available. So when can the normal, like all the people get it? Actually, when the vaccine is available, it's going to be first deemed, it's going to be first given to the people who are deemed essential by the government. And that's going to include military personnel and healthcare worker. And then it's going to be one after that, it's going to be available for everybody else. We're expecting the vaccine to be 2 shots, 1 month apart. And after completing the second shot, then the immunity will be higher. But again, we don't know for how long it's going to last. Same thing actually when we talk about the antibody, we don't know if the antibody is providing really good immunity or not. We don't know. When will the world be able to get the vaccine? Actually, people in the developing countries are gonna wait more, and they're not gonna be able to get the vaccine until later. So if we're talking about 2021 in the United States, who knows, when they're gonna be able to get the vaccine. How about the Chinese vaccine? I'm sure people are, I mean, you're hearing all kind of things about Chinese vaccine, Russian vaccine. Actually, the Chinese vaccine is available now, and actually they are using this experimental vaccine on certain population outside of clinical trials. That's not going to happen here. Actually, I mean, here we need a lot of regulations. I mean, before we can approve anything, which is it's a good thing. Again, I'm glad we have these regulations. The Russian vaccine, I know President Putin a few days ago, actually, he announced that, I mean, they are the first country to have the vaccine. But again, unfortunately, if you dig through this actually in more deep, usually it's, I mean, they should go through different phases before approving a vaccine. They did not go through, I mean, adequately through the final phase or phase 3 trial. So the safety data is not really clear. Again, they started actually selling the vaccine to other countries, but again, I mean, me or all the scientists are really hesitant to, and I mean, we have some skepticism when we hear that. So as far as, again, the vaccine, more than 6 drug makers are currently working on providing the vaccine. The most promising one actually is the one from AstraZeneca, which is doing a study that, I mean, they're completing their study in Britain, and they're expecting that they're going to have some result by August. But again, even if that's, I mean, if all goes well, again, this is, I mean, I don't think we're going to have any vaccine until November, December, and maybe early next year. I think. So again, the other thing, I mean, just to give you an idea about the vaccine, the usual time to provide a vaccine and study it very well and study all the side effects and the immunity, produced by the vaccine usually is 5 years. So knowing that, you can imagine that, I mean, now with few months or like couple of months or a year, they're working hard to produce a vaccine. So I would be really careful when I think about the vaccine and just, about interpreting the result of the vaccine. So again, we're going back to the key thing here is prevention. So, and again, I'm sure you've heard this so many times, but I'm gonna say that over and over again. Unfortunately, COVID-19, now it's like, what we need to do is we should get used to the new life with COVID-19, if you want to call it this. That's our new norm. It's going to be with us for a while. Unfortunately, we don't know for how long. 1 year, 2 years, who knows? So the best thing to do is just to go to the basic of when we have any pandemic and just minimize social gathering, minimize any activity if it's unnecessary. I know it's unpractical to close the schools and offices for years and years. So the school is going to reopen. What we need to do, we need to practice safe habits, and that's what the schools are trying to do. They're decreasing the number of students. They're doing like the face mask as mandated. The teachers are going to be wearing eye shield. The social distancing is very important. Hand washing, frequent sanitization of the surfaces. That's, all these basic things, that's the only thing we have at this point. And when you are in doubt, you can always check the ODH and the CDC website. They have really good information about update on so many things, including travel and regulations, and you can always check that. But again, the key thing is really prevention, prevention, prevention. I think that's all what I have. I think we finished earlier than expected, but I'll be happy to take questions, comments. So I will end now and leave it open to discussion.
Jazakallah khair, Dr. Sabbagh, thank you so much for that amazing content. We do have a few questions already in for you. We will start with a question in regards to the vaccines and the norm. The question reads, do you think that a vaccine is all what we need to lift up the mask orders and go back to quote unquote pre-COVID norm?
The short answer actually again is no. I don't think the vaccine by itself is going to, again, I mentioned that, that it's not going to work like magic. It's going to help decrease the spread of the virus. We don't know for how long it's going to take just again to have immunity in the community. So I don't think the vaccine is the only thing. I think we should stick to the basic things, the things that I mentioned. The new norm with just face mask and hand sanitization and social distancing. Plus, when the vaccine is available, that would be a good thing.
Another question asks, what are your thoughts on clearance testing for asymptomatic patients? And do you mind also explaining what clearance testing looks like?
Okay, clearing testing, again, I'm not sure if they're asking in the hospital. In the hospital is a little bit different than in the community. Like in the hospital, again, we had this problem where when we have somebody with COVID-19, in certain patients, we would test for example, when we're gonna send the patient to a nursing home, they require a clearance test, meaning they require a negative test. So we were doing this test every 2-3 days and it was still positive. So that's why I said, the test can be positive for a long time, but now the newer, that does not mean they are still like spreading the virus or contagious. So that's where the clearance testing, actually, initially it was only like a a lab test, like a PCR or antigen testing. Now we're doing also clearance by symptoms. So if somebody, start having symptoms, for example, on day 1, and by day 4 or 5, or whenever, they're asymptomatic, they're back to their normal and they're afebrile, they have no fever for 3 days. Most likely, if either that or more than 14 days since the beginning of symptoms, so whatever actually takes longer, either the symptoms or like the counting days, they're most likely clear. I'm not sure, again, if that's what they mean by the clearance test, or they mean on, I hope that answered the question.
I believe we can move on to another question that was very informative. Another question reads, does a positive antibody test necessarily mean immunity?
Unfortunately, it does not. The antibody test, again, I mentioned, I just mentioned that actually for a few weeks it will be positive. It does not mean necessarily that it provides immunity. Saying that, actually, from our few-month experience, or actually a couple of month experience with COVID-19, it's very unlikely to have reinfection after maybe 2 months. But again, it doesn't mean that the antibody is providing immunity for like a long time. Again, the short answer, the antibody positive test does not mean immunity. They can still get the COVID-19. Again, because again, I mentioned also that the antibody test, we have so many antibodies and so many companies produce different tests. And usually each test check for one of the antibodies. It's not like there is no test that will check for everything. And when the result comes back, usually it comes as a number. So again, it's not like positive or negative. So that's why I said, it's really hard to interpret the test, and it does not mean that the patient is immune.
Thank you. Another question asks about a concern a lot of us are having, especially with schools and restaurants reopening. Can asymptomatic positive tested people go back to work after a certain while, or is there limitations to when they can be working?
Well, I think it's a similar situation to what we do in the hospital. If they are asymptomatic and they have a positive test, it's either they are pre-symptomatic and they might develop symptoms soon, or they had the disease and now they have a positive test, but they're not infectious. That's where actually the antibody test is helpful. So in this scenario, I would check the antibody test or the serology, the blood test. And if they have high antibody titers, that means more likely they had the disease, they form antibody, and now they are not infectious. Again, now if we're saying they have no symptoms whatsoever, that means they're more likely they're not going to spread the virus, because again, these tests are going to test a very small number of the viral genome, and they're going to be positive, but the patient is not infectious. So yes, I would say in this case, they can go back to school or work, but they should wear a mask and follow all the other restrictions.
Thank you. Another question asks about your treatment portion of the lecture. They ask if you recommend prescribing steroids in general as soon as diagnosed, or based on symptoms themselves? And if the treatment options you mentioned are for outpatient settings or inpatient ones?
Okay. Well, the treatment that I mentioned, most of them are for inpatient. Like the steroids, I would not recommend it for outpatient. Again, the study, the one I mentioned that changed all the recommendation was for inpatient and they were on oxygen. So the answer, really, the short answer, I would not recommend steroids for any patient as soon as they are diagnosed. For outpatient, again, we have very few options. Again, chloroquine or the Plaquenil, some people are still prescribing that. Actually, there are some studies now, about prophylaxis. So if it's going to provide some immunity, that's really, it's not clear. I mentioned some other treatment, but none of them really, I wouldn't recommend anything like as a go-to for outpatient.
Thank you. We'll move on to another question asking, from the patterns you see, do you think this will be a virus that has long-term complications like EBV, strep bacterial infections, and what would its impact be on other systems?
Well, we're seeing already some, actually people with, we're seeing people having like lung problems a few weeks or a few months later. Like some people are still on oxygen after having COVID-19, so they recovered, they're feeling better, but they're on oxygen. I'm seeing people with, again, fatigue. There is something called chronic fatigue syndrome. We see that, in the outpatient setting. We see post-Lyme syndrome. I think with COVID-19, same thing is going to happen. And again, now we're collecting more information and more data. But again, I think it's a virus that affects every single system. And we might see late manifestation or late consequences in every single system.
Thank you. And so far we might be almost done with questions. So just a heads up for anyone who may be holding off with questions. This is your chance to ask them before we end the webinar. We will go ahead and address another question here. If a vaccine is approved, would it be a yearly vaccine like the flu vaccine? I know you've already addressed this topic and said that we don't really know how it will be required, but do you have any predictions or are there any studies that are exploring this topic specifically?
Really, we don't know yet because we don't have the vaccine yet. But again, I'm predicting it's going to be similar to the flu vaccine. Again, I mentioned that it's going to be most likely 2 doses, 1 month apart. We don't know what kind of immunity is going to provide, and we don't know if it's going to be a yearly thing or that's really, we don't know.
Mm-hmm. Well, thank you for all of your answers. It looks like our questions may have all been addressed so far, and we're not getting any other ones. So I will assume that will be the end of the Q&A for us. Thank you so much, Dr. Sabbagh, for addressing all of these questions. Mashallah, we did receive a couple more than we expected. And thank you so much for your enlightening content. I would like to remind everyone that this webinar is recorded and will be shared on our Noor Ohio YouTube page as well as our Facebook page. Dr. Sabbagh has returned for this webinar and we're very grateful for that. We hope COVID doesn't last long enough for us to need more lectures, but we hope to see you back with us again regardless. Thank you all for tuning in, and please consider donating to the Noor Islamic Cultural Center to sustain this virtual content that we are trying to put out for everyone. And thank you once again, Dr. Wissam Sabbagh. We appreciate you.
Thank you so much, everyone. And hopefully, inshallah, stay safe. And again, I hope it will end soon.
Inshallah. Assalamu alaikum.
Thank you. Alaikum salam.